Okay, okay, Mohammed. So this is the second part of the low-extremity peripheral practice. So, Mohammed, you want to start because you are not here
Yes.
yesterday?
Bismillah. Yeah. 73 years old man present to the clinic with pain in both of his feet that wakes him up from sleep at night and gets better when he dangle his leg off the bed. He has been followed up in your clinic for claudication and was on walking program and optimal medical therapy. He stated over that He stated that over the last week his pain now become unbearable. He has prior history of smoking and has had no abdominal surgery. His last ABI was zero point 0.7 bilaterally, and this visit now is 0.4. Okay.
So what do you think is
So,
going on with this patient?
yeah, so this patient now is moving to CLTI from claudicant.
Okay,
Although he's medically optimized, so he will require intervention. So I'll start with history and examination.
let's go to the
No
question.
patient.
Okay, but
Yeah.
again, Mohammed, in the exam, just
Yes.
answer exactly the question. You know, what do you think is going?
Yes.
The patient has also now, as you said, from claudication to critical limb ischemia. Don't talk
Yes.
about measurements. He don't ask you yet. You know, so just
Okay.
stop. You know, because again, timing is important. It's an exam, so timing is important. If they
Sure.
ask you later on, it's different. Okay. So let's say first question, how do you proceed? Now we ask you, how do you proceed?
I'll proceed with a full history and examination,
Okay.
including past medical and past surgical history, and the history of how active is the patient, and prior coronary stenting, prior stroke, MI, and
Okay. Next.
a full examination, including cardiovascular examination and neuro exam.
Okay. And the most cardiovascular, you mean vascular. Okay. You mean pulses.
Yeah, pulses and everything. Yeah,
He stated he has not been ambulating much due to the pain. He does
okay.
he does note buttock claudications and erectile dysfunction for the past few months. On exam,
Mm-hmm.
there's absent femoral popliteal and pedal pulse bilaterally.
Mm-hmm.
There are weak monophase signals in bilateral feet, and there is no wounds. So what do you do
Okay.
next?
Okay. So since there is no femoral pulse, I have two options. CT angio is the best option for me. CT angio with runoff.
Okay, so you don't say it's two options.
Okay.
I was going to ask
Uh,
you what is the second options. You know, just go
okay.
back the
Yeah,
way
big
this
one.
patient, as you
Okay.
said, no pulses. We don't know what the level. It looks is high.
Okay.
Could be a level of the ilia, could be the aorta. So I get CT angiogram, so I know my anatomy, and that's
Okay.
it. You know.
Yeah.
But then
Can
in the
people
exam, too
can
much
people
talk
do
is not good.
diagnostic angio, doctor, for this?
You can do
Diagnostic
that. I have no
angiogram?
issue. But you have I have to
Okay.
ask why. You have to tell me because we don't have CTA in our hospital. I accept that.
Okay.
But if you have a
Okay.
CTA, why should go do invasive? You know, doesn't make sense to me.
Right.
But
Right.
if you decide, okay, I'll do an angiogram, which is okay, I have no problem with that. But you have to have excuse, which you can tell me, okay, because I work in Bifra Hospital, you don't have CT angiogram, you know, or the second reason his renal, function is borderline because with angiogram you give less contrast than CTA,
Yeah.
and you can't justify it. I just have to justify whatever,
Okay.
but don't
Sure.
give both. Don't tell him I can do angiogram or CT angiogram. In my
Okay.
opinion, it's not a good answer. In my opinion, you just give, I do this one or this one. Always give one answer and stop, okay?
Sure.
All right, the lab were normal and the CTA showed occluded infrarenal aorta and bilateral common iliac artery. There is a reconstitution of bilateral external iliac artery with retrograde perfusion of the internal iliac artery. The common femoral artery are moderately diseased and both SFA are occluded. The deep femoral artery are patent and collateralize the popliteal artery and tibial artery. What are your surgical options for revascularization?
Okay. I would go with our two bifemoral bypass.
Okay, that's good. Why don't tell me like or something? That's good.
Yeah. Yeah.
Why not aorta by iliac?
So the common iliac is occluded. External iliac is not good conduit for bypass. I prefer to do aortobiofemoral and leave the femoral retrograding the internal iliac supply.
Okay.
Mm.
If he's like, bad heart, conditions and he has multiple donor surgery, what other option you can do?
I can do auxiliary biofemoral.
Okay, bypass. That's good.
Yeah,
That's
bye
okay.
bye.
EKG is normal. Echo showed ejection fraction 65. And there's no reversal ischemia on the stress test. What operation you going to do? I mean, we just talk about it.
Yes.
You're going to do the aortobiofem. Patient agree. How do you configure this reconstruction? They want to know.
Yeah,
Not
end to end or to end to side.
the proximal, correct. What are you going to
Yeah.
do?
As, I I prefer end to side to keep
Okay.
the flow to the IMA, and that's it. Yeah.
All right. This is the right answers. Because if you do end to side, it's nothing to do with the IMA. IMA getting from the external. You remember the aorta and both common are occluded, correct?
Yes.
And so you do end to side, it's not going to help. If it's the opposite, yes. If he has external artery occluded and the internal coming from the common and aorta, you do aorta bifem, then you need to keep the inflow to the internal from above, then you do end to side. But when the aorta and both common iliac artery are occluded, then, I mean, you can go both options. Put it this way.
Yeah,
You can go
both option is correct.
End to end or end to side, But if you want to tell you why you want to do it, they don't tell me it for internal iliac. No. Justify is that end to
For
side.
IMA, I said IMA, but yeah, but it's the same option.
IMA.
Yes.
How do you know the IMA is open? Did they mention it's open? I don't know. We don't know it's open.
Yeah.
Right. And second thing, IMA is not very important. So I will not, it's not to be a good excuse.
Okay.
So if you're going to do end to side, because it's just technically easier, But if you end to end, it's more difficult, but more physiological, because end to end. But again, you can figure out both in this situation, you can figure out whichever, but you have to say why. So I will say, okay, I'll do end to side, but the reason why is just technically easier. I have more control on the aorta, because the moment you cut the aorta, you lost the control, and you have to do it. If you have any problem, aorta is bad,
Yeah.
So and see most of it describe the procedure. Yeah, describe the operation. So I'm going to do a
first, as we mentioned, preparing the patient everything, and I will start with both groin incision, going of skin subcutaneous tissue to the inguinal ligament and identify the common femoral sheath, opening the sheath, have good control to the common femoral artery profunda and the SFA. Then start my tunneling from down, doing the same in both groins. Then go to midline laparotomy with exploratory laparotomy, then mobilizing the transverse colon up, but a fixed retractor, mobilizing the small bowel to the right side, ligating the IMV, doing visualizing the infrarenal aorta, get a good control, and mobilizing up to the duodenum and the left renal vein up to a good, having good healthy segment of the aorta for my clamp zone, proximal and distal. Then ask the anesthesia to give heparin, then clamp the aorta, start my um, first anastomosis with bifurcated graft, depend on the size I have, and doing my first anastomosis, then try to do the tunnel afterwards, after the anastomosis, to make sure there is no kink and the graft under tension, then do my both anastomosis on the common femoral artery, aiming more toward the profunda because SFA is occluded. After that, check the flow over the graft. After the anastomosis, check the flow over the graft and check the flow over the pedal pulse if it's improving or not. Then close then the closing the abdomen, then the groin, and that's it.
Okay. You see, the problem when anything you don't mention it, I have to presume that you're not going to do it, correct?
Okay.
Even if you're
Okay.
going to do it in your life, okay?
Uh,
You didn't mention anything to me about the ureters, you see?
yeah. Okay.
And so I'm assuming
I thought. Yeah. Yeah.
it's an exam.
Yeah.
I'm sure you can do it in the surgery, but an
Yeah.
exam
Yeah.
is important. Because
Yes.
for me, it's the most important part. So if you don't tell me about ureter, I think you may turn in front of the ureters. So it's very
Okay.
important. When I want to tunnel, I be sure that I am behind the ureters.
Yeah.
Okay,
Better. Okay.
I have to
Sure.
identify the ureters and go behind it. This is very important step of the procedures.
Okay.
Okay.
Sure.
The second
Yes.
description, the procedure, then tell me where you're going to clamp. See, I clamp the aorta. Then tell me below the renal, above the renals,
Mhm.
what's your level,
Yeah.
which is
Okay.
an important, I
Okay.
forgot what the if it's CTA showed infrarenal aortic occlusion. So you have to clamp where? Because it has infrarenal occlusion.
Suprarenal. I will need to go.
Suprarenal.
Yeah.
Then you have to tell me how to mobilize the renal vein, right?
Yes.
Because you have to go to suprarenal. So you have to
Mm.
tell me either you're going to cut it and reanastomosis, or you're going to mobilize by cutting the gonadal vein and
Gonadal vein and
vein
adrenals.
So this
Yes.
is an important part. I'm sure you can do them in real life, but you see an
Yes.
exam, so you have to mention
Yeah.
that. So just be careful.
That's why they didn't mention. So I said I will find a healthy segment of the aorta and I will clamp it. But for sure, if I'm going suprarenal, I will ask the anesthesia even to give mannitol, and I will clamp suprarenal after mobilizing the renal vein.
Okay.
Yeah.
This is the only thing. And the rest of the word described, I think it's okay with me. Okay, let's see. The patient is ICU, so he did that, and patient did fine. Patient is ICU recovering after surgery. And later that night, he complained of tense pain in the right foot at rest. The nurse stated that the pedal signals are gotten weaker since the last check. What do you do next?
Okay, I will ask the nurse to give to start him on heparin infusion drip,
Okay.
and they will order for CT scan, urgent CT scan.
All right. Looking for.
Looking for occluded limb and graft, but I want to make sure.
Okay. You can do that,
Mm-hmm.
or you can do,
Or can
just
take
take
him.
ultrasound, just put,
Yeah, I can do ultrasound, and they take him back. Whatever is easier in my institute, I will do.
Right. So you can do a CT angiogram, or maybe just go duplex ultrasound to confirm
Yeah.
it, or maybe if
Yeah.
it's a patient thin and you can examine him, because the problem is the area standards,
Yeah.
sometimes just by exam, if you don't feel a pulse, then you know that
Yeah.
there is problems,
Right.
So the most important, again, you don't want to delay this patient. Again, as you said, which one is easier? But don't wait for next day, to get the CT
Yeah.
angiogram. Or either they can get like within an hour, or I get like a duplex ultrasound. If it's too late, just check put your hand, no femoral pulse, your graft is occluded, then I just take him back. So,
Take him.
okay.
Yes.
You do any thrombolysis?
First day, no.
No. Okay.
Yeah.
All right, let's see what the next. So on the exam, the right femoral pulse, they did an exam here. So the exam right pulse is now absent. The femoral pulse is purple. Pedal signals are present bilaterally, but much stronger on the left. What do you think is happening? What do you think is happening?
Yeah, it's occluded limb.
Correct. So occluded
Yeah,
okay.
and
So
most likely the problem is on my right side distal anastomosis because
okay.
the left is still working, so the proximal is okay.
You're back in the operating room with abdomen and right groin exposed. Brief explain your plan. What we're going to do.
So I will start with the groin. I will open the anastomosis distally. I will check the flow coming from the graft. I'll do thrombectomy. If the flow is very good from proximal, I will know that the problem is distal outflow. So I'll open more toward the profunda and I'll mobilize my graft anastomosis to the profunda for good flow, and they will check the flow again with
All right.
batch. I mean, yeah.
Well, I'll tell you a couple of things. First, you see, we are back in the operating room with abdomen and right groin exposed, you know. I don't know why they said abdomen. I will not open his abdomen. You
Yeah, I
see,
will not
sometimes
open his abdomen.
we not agree, whatever, because remember, guys, whoever write the book is a person, you know. I always keep saying that book is okay, but it's not like astaghfirullah azim mithl Quran. You know, we can criticize books, you know. So this one I will not. Why need to open the abdomen, you know?
Yes,
I mean,
yes,
why open the
I have good. Yeah.
You see? So I don't agree with that. I just go open the groin. When you said you take the anastomosis, when he takes anastomosis, already fresh anastomosis, already done it. I just cut the graft. This is a graft. It's easy to cut above it, you know. The anastomosis, longitudinal incisions, you know. And then you do thrombectomy and you can look from inside. So you open the graft just above the anastomosis without disturbing the suture line. And you look inside and you see what is the problems, you know. And you can do thrombectomy. Then if you have to extend, then yes, you have to extend, you cut the suture line, then you have to put a patch. But if you solve it, you know, because sometimes it could be a kink from the graft itself, you know, then you can just put stent or something above. It's not always a problem. This could be proximal, you know. But the most important that you see, I think the reason why he opened the abdomen, that when you do thrombectomy, you have to be careful that blood will not go to other side, you know.
Yes.
So usually what we do when we do thrombectomy, we put pressure on the left groin. You know, we press so we can close the left common femoral artery. So if any clot will go to the internal, will not go to the contralateral limb, you know. This is the only things. And then when you open the graft, you don't have to put a patch because the graft, they don't heal with intimal hyperplasia, you know. The hyperplasia happen only in the artery. So if you open longitudinal the graft, you can still just do primary closures, no problem. Okay, especially the graft usually is open, big, you know. So this way I will explore it. Okay. So let's see what happened. So you open the right anastomosis and you observe a dissection flap at the origin of the deep femoral artery with some sluggish back bleeding. You pass the embolectomy balloon proximally, retain fresh blood, and restore bliss. How do you address the dissection?
Okay, I'll open the arteriotomy more. I will try to batch repair the area of the dissection.
Okay. I mean, if you can see it and easy to access it, I just do both.
I can do tacking, yeah, tacking suture or batch.
Otherwise, you have to open all the way to profunda and put a patch. Then you put a patch, you know. But again, remember, guys, don't I want to address this idea that when you do it fresh, you have to be careful about suture line. When you cut the suture through the suture, you have to tie them back again. And redo after a couple months, you don't have to worry about suture line. You just cut and put a patch, you know. So I want to be sure this idea is clear. All right, here's a different scenario. Same patient present with a blue toe to his bilateral feet and wrist pain of the left foot with a third toe ulcer. Okay. He has no bubble pulsatile donor mass, but there is an epigastric bruit. He has bubble femoral pulses and right pedal pulse and biphasic left pedal pulse. What's your assessment plan? So they are starting complete different scenario now.
Yes.
So blue toe syndrome.
Blue toe syndrome with palpable pulses.
Pulses and biphasic pulse. Okay.
Okay.
What's your assessment plan? What are you going to do?
So I'll do a CTA to make sure what is the cause of the blue toe syndrome, including the chest, abdomen, pelvis, and echo. To know more. Yeah.
I think I agree with that. You have to do a CT angiogram, you know, and I mean here I think the CT is the most important.
Yeah.
They mentioned about TE and echo. I am not very convinced because usually when you get the blue toe syndrome in the legs, the majority of the problem either in the aorta or peripheral. You see, when you get blue toe, blue fingers, then you think about the heart. But it's very rare to get an microembolization. You can get big emboli from the heart. You might get like blow toe from the heart. I mean, I almost never saw it. So or blue toe comes. So I concentrate on the abdomen and lower extremities. You know. But if you talk about the finger, then you have to think about the heart with TE and all the things, you know. All right, so did that. TE is negative. They did TE here, which is it's okay. TTA demonstrate focal mixed density distal thoracic aorta plaque, 50% aortic diameters. There's also left multifocal moderate SFA stenosis, above yes 50%. What do you do next? Okay, this is a common scenario. So he came with a Bluetooth syndrome. You do a CTA and you find a mixed density distal thoracic plaque, 50% stenosis, left multifocal moderate SFA stenosis, but yes 70%. How would you do next?
Okay, so we start first with put the patient on medical treatment,
Okay.
Oral anticoagulation with antiplatelet. Put him statin 2, and I will wait for this patient. If he develops anything with the medication, I will start intervention.
Okay.
What do you
I
think?
agree with that, even though in the book they said no, they wanted to go with the procedures. But I don't think so because I don't see any. I'm looking, is any ulceration? There's no ulceration, right? Bit of pulse, but unless if he was already on antiplatelets, then you have to address it, you know. So,
If he's
so if
medically
it's not like
optimized,
already
if
optimized,
he,
then next thing you have to intervene.
yes,
If it,
intervene.
correct. If he's never
So,
been on antiplatelets, then I will watch him and do antiplatelets, and I'll watch him, you know. If does not get an approved, then you have to intervene, you know. And how we intervene, how we fix it.
So I'll start to fix with the most probable cause, which is the thoracic aorta. I will do TVAR with covered stent.
TVAR carcin, correct. 50%, so you put a cover stent.
Yes.
SFM or BTL artery. Do you address them or not? I think this one you address them because here it's different. It's not like rest pain embolizing, so you don't know what's really causing that.
Yeah, but I have to stent them, both of them.
Sorry?
I have to stent them, not only balloon them.
Not really. I don't stent BTL. I mean, rarely.
Yeah,
You
but
know, it depends unless you do dissections. You know, all depend on the surgery decide. But you start with the ballooning first and see how it looks. If you don't like it, then you do stent it. But is most probably is coming from the aorta, you know, from the plaque, you know. Rarely SFA and BTL, you know, plaque give you embolization unless you're aneurysm. So when you talk about embolizations with a Bluetooth syndrome, most probably big artery like an iliac. Even iliac is rare. Mainly you talk about aorta really, thoracic of the aorta. So if you're going to address the lower one, it's just to increase blood flow, just to increase his flow. But I will concentrate on aorta, and then I will decide, depending how bad, then I'll decide to address the SFA or BTL. So this is the advantage you see of oral exam. You can talk. You see, in written exam, only 1, 2, 3. But in the written, you can argue, you can talk. Say, this is the way you discuss to him. He knows that what you're doing, you know. I think the last one question. Why not just do an inflow operation as this patient like you did on the last one? Why you just do the inflow operation did on the last one?
Because this patient presented differently, so he has symptomatic lesions that can cause showering. So I have to address all of the 3 of them to prevent that.
I mean, they're saying the patient has a toe wound, but I didn't see toe wounds. Did you see? I know this is their answer. They said the patient has a toe wound, so that's why you have to address it. But you're right, he has an ulcer here. We mentioned this. So he has third toe ulcer. That's the reason why we have to address.
Presented with tissue loss.
Yeah. So I didn't see that. Yeah, you're right. Then you have to address it. Yes. Because it's so why not? Because we have two ulcers. If it's not a toe ulcer, I think this as you said, we just do an inflow. Anytime you get a wound or ulcer, then you have to address the inflow and outflow both.
Yeah.
All right.
You have to have inline flow.
Yes. I think this is finished. I think so. Yes, finished. Okay, let's go to case 4. Sam, you want to take case 4?
Okay. 75 years old woman presents to the emergency department with worsening wrist pain in the left foot without wounds. She has a history of coronary artery disease with 2 stents placed 5 years ago and surgical history of a total abdominal hysterectomy and a colostomy from a colon resection for cancer. She takes aspirin and high-dose statin daily and continues to smoke a pack per day.
Okay.
So
must
left
have been
foot,
what you do.
wrist
Like,
pain.
correct. So what do you do next?
Um, لا, we'll take proper history يعني we'll ask more in the history and do proper physical exam. We'll concentrate on heart function, lungs, the onset of pain, similar condition, other risk factors, and perform examination to assess the heart, lung, and vascular, distal vascularity pulses and neurovascular. And
Exactly.
also, okay, we
That's enough.
order investigation.
That's enough. That's enough, you know. If he think he's stubborn, he want to talk more, you can talk more. But that's but the most important, guys, to concentrate on physical exam and the pulse because it's a vascular, okay?
Okay.
So let's see what happened. The pain in the foot started about 1 month ago and has become so bad she can only sleep with her foot in the dependent position. She hasn't been walking much because of pain. Physical exam is normal except for dependent rubora of the left foot. On the right, the femoral pulse is palpable and the pedal signals are biphasic. While on the left, the femoral pulse is non palpable and the pedal signals are monophasic. EVI is 0.6 and 0.3 on the left. Is there any other testing you want to do?
Yeah, I want to do CT angio of the lower limbs to assess the inflow.
Correct. So let's see what we're going to say here. Sorry. CTA demonstrate no significant right. You see, this is a good answer. That's it. CTA demonstrate no significant right iliofemoral disease with a long segment SFA occlusion with execution of the above knee popliteal artery and intact tibial runoff. So on the right, you just have SFA occlusion, okay? On the left, which is the symptomatic leg, right? Yeah.
Yeah.
Which has a rest pain. The common iliac artery has a short segment occlusion. The external iliac artery and the left femoral artery are severely diseased.
Okay.
Okay. Additionally, the SFA is occluded throughout the thigh with the constitution of above the knee popliteal artery with no significant infrarenal disease. How do you interpret this finding? What would you do next? So what do you think is going on?
Since the patient is having only wrist pain and no ulcer, I will fix the inflow only. So I will go for femoral endarterectomy and retrograde angioplasty of the iliacs with possible stenting.
That's good. Let's see what here. So the blood workup is negative. Describe your operation. How are you going to do it?
Okay. I will take patient to OR after. I will consent the patient to take patient to OR, prepare the from nipples to mid thighs bilaterally, and go to the left. Explore the left common femoral artery through longitudinal incision below the inguinal ligament. Control common femoral artery, profunda, and SFA. Give patient heparin, therapeutic dose 80 to 100, ACT more than 2050, longitudinal then I will clamp the artery, then longitudinal arteriotomy, remove the plaques, tuck the flaps, and make sure of the inflow and back bleeding. Then I will patch, then I will go through the patch with wire and sheath and do angiogram, then pass wire across the lesion, do angioplasty, check for any dissection. If there is dissection, I will put a stent. Then I will remove the. I will do completion angiogram. Then I will remove the sheath, put per string, and put drain and close the wound in layers.
Okay, that's good. That's enough. You said the common iliac is completely occluded, correct?
Mm.
So you think balloon angioplasty be enough?
يعني if I did balloon angioplasty and it's open, no dissection, no flow limitation, more ما في stenosis more than 50%, it's enough. Otherwise, I will put stent.
Cover or uncovered balloon or non or balloon expandable?
In the common femoral, in the common iliac, I used to put balloon expandable covered stent, and in the external iliac uncovered stent.
An external iliac is balloon expandable or self-expandable?
In the external iliac, self-expandable is fine.
Why not balloon expandable?
Balloon expandable, we use it to be precise in deployment, to avoid coverage of the important branches like internal iliac artery. Self-expandable is fine.
Now the self-expandable now is become very good. You can get a really very good precise deployment. So why I don't use self-expandable, in the common also?
In the common, self-expandable in the common. Yeah, أنا يعني in my practice, self-expandable covered stent can be used, just not to cross the aortic bifurcation or the common femoral artery bifurcation.
Okay. First, don't say in my practice because I didn't graduate yet, but so it's not a good, because this is I have to teach you guys also the wording. It's not only the information,
Yeah.
So you don't say it. You say my practice looks like you being, graduate like 10 years ago, and which doesn't sound right,
Okay.
Second thing, it has to have explanation. First, common iliac artery, complete occlusion. This is task D, correct? We know task D, covered stent is better than uncovered stent, So the common iliac artery, if it's task D, C or D, always we use a covered. But the paper showed that, the trial. You know what's the trial name?
Compass.
شو اسمه؟
أعتقد compass ولا بازل.
No, not compass. No.
في بازل trial.
No, not Basel trial. Go and read it anyway. So this is the trials, okay? This will be your homework because you have to read about this trial. It's important, iliac artery. It showed that the covered stent for task C and D is better than uncovered stent. So when you have a complete occlusion, we have a tendency to use covered balloon expandable. In the common iliac artery, always use balloon expandable because it's stronger. You see, common iliac artery usually is calcified, because it comes from the aorta, And you said you don't go to the aorta. No, not the opposite usually. If it's a flush occlusion of the common iliac artery, you have to go to the aorta because the occlusion starts in the aorta. If you do just flush occlusion and you do the stent, it's just flush at the aortic bifurcation, you may miss the lesion. So that means you have to go from the other side sometimes and put and to support, you can put uncovered stent to support, Task A and B, if stenosis, you can use uncovered stent. But when you go to C and D, then always it's better to use a covered stent because better patency. Yes, you can still use balloon expandable, self-expandable stent, but it's only for stenosis, And the only reason I use them for the length, because the balloon self-expandable, the balloon expandable are short, self-expandable is longer. So sometimes if you have a long lesion, you want to use just stenosis, then you can use self-expandable. But usually in the common iliac artery, always we use balloon expandable stent. If it's C and D, we use covered. If it's A and B, uncovered will work fine. Okay. External, rarely, almost never we use a balloon expandable stent in the external because of tortuosity, not because of the precise deployment, because of tortuosity. Because external iliac always very tortuous, so you need to have a flexible stent. If you use a balloon expandable stent, it's stainless steel, it's very stiff. This is a problem with the balloon expandable. Common iliac artery is always fixed. Rarely, you don't see tortuosity in the common iliac artery. The reason why we can use balloon expandable. But external iliac artery always tortuous. So you have to use a self-expandable stent, uncover stent for the external iliac artery because of the tortuosity. All right?
Okay. Okay.
Clear?
Clear.
Okay. So you did that. Let's see what happened after you did all the procedure. What happened if you couldn't re-enter the trumen when attempting to cross the iliac and you remain subintimal? So you try because complete occlusion. So as you said, you finish you put your sheet, you try to go there, which is common scenario, and you are subintimal, you cannot go. So what do you do?
I can use re-entry device.
And I will use the re-entry device. Okay, yeah. It's not available. What do you do?
We can try. I can try from contralateral limb crossover, or from the brachial artery.
Okay, I will do that before re-entry device, because it's cheaper. You know, we don't need to jump to expensive things. So first, you said I'll try from contralateral limb to go antegrade. If I cannot, I go from breaker, as you said. You know, if it doesn't work, then and I have re-entry device, you can try re-entry device. Okay. Well, let's say all of them did not work. What do you do?
I can do. I will do fem bypass.
Yeah, that's it. It's very simple. Then I do fem bypass. Okay. Let's say you are unable to cross the lesion into vasca. What would you do with the left SFA occlusion? Let's say that you were able to cross the lesion into vasca. Okay, so you did that. You fix it. What about left SFA? Are you going to fix it or no?
I will leave because the patient is only complaining of wrist pain, so the improving the inflow is enough. Okay. Since there is more ulcer. Yeah, I will leave it.
I'll leave it. What if the indication were for non-healing pedal ulcer?
Yeah, we have to do then fem pop bypass.
Okay, where's the popliteal occlusion? Above or below the knee? I forgot.
Above.
Above the knee. Okay. Well, let's see what next. What do you use, a prosthetic or conduit?
For above, yeah, for above knee occlusion, if the popliteal artery is patent above the knee, then I can use both, but always venous conduit is better.
Okay, can I argue this way? I mean, I have no problem with this. Not, but no, better is wrong because study showed is no different, correct?
Yeah.
Then why use prosthetic? So people, the data showed is no different between prosthetic and vein. So you can go either way, either of them, you know. So you can argue and use prosthetic and leave the vein later on for more distal bypass. You know, you can argue this way. I have no problems. You know, you can say I will use the vein because I'm like risk about infection is less. Is maybe, you know, but you don't say it's better because the data do not support that. Okay.
Okay.
All right. Let's back and say you had to do femoral artery to femoral artery bypass as well as femoral artery to above knee popliteal artery bypass, and she's now has a valvular pulse in the left foot. Good. When she wake up from a surgery, she's now has wrist pain in the right foot, and she didn't have before. What will you do? So what happened, you think?
Steele syndrome.
Steele syndrome, correct. So what do you do next? Because left foot, you know.
We can do arterial duplex to assess the or ABI to assess the right lower limb to check the inflow. or to assess the anastomosis if it is
But look, Bassam, you have a Steele syndrome, correct?
yeah.
Steele syndrome, that mean either you have an iliac stenosis, as you said, you miss it, but the CT, they said, there's no occlusion. So you have to presume that's correct. You cannot, there's an exam. I mean, in real life, you can go back, look at CT, be sure you didn't miss any lesion. But when they tell you the inflow is okay on the right, you can argue with that. You have to presume it's normal. So it's not an inflow, okay?
It's technical mainly.
No, why technical? It's a steel. And steel because it's SFA occlusion. And the blood will go to low resistance because you did FEMPOP. If you never did FEMPOP, you will not have a steel.
Good.
You did a FEMPOP, now the flow is easier to go to the left than the right because the less resistant, right? All blood go to lower resistant side. So it's easier for the blood now to go to the left through the graft than to go to the right. So the reason why you get that, nothing to do with technical problem. It's just because physiologically now you open the SFA on the right, SFA in the left is still occluded. Sorry, the opposite. Left, you open the left SFA and the right SFA is still occluded. So the blood has tendency to go more to the left than the right, so you get the steal, you know?
Yeah.
So what you do in this one, I mean, just have some.
We have to do SFA angioplasty.
Okay, but it's a flash occlusion, I remember from that, but you can try that. Okay. But remember, this patient, he just came out from surgery and you already have a two, you have to be realistic in your, it's not just talking this time. You have to realistic. You already have both groin open. You already did the fem bypass, you know, just came from surgery. This is next day. I'm going to take her to do SFA angioplasty now. No, I mean, she's just pain, right?
Yes.
Yes, she has a risk. It's not compromise the leg, you know. Give it some time. But what happened is that this is the high resistance, the low resistance in the leg. With the time, it get less and less, you know, because you just open it now, you know. So most of the time, until the heart, you know, you adjust to a new situation, the leg will really perfuse. So I will wait. There's no rush, you know, unless because it's not like a cold leg. It just came rest pain. You still have a good signals. I just wait and see, because they improve. Maybe some exercise that will improve. So don't jump to a less, because it's not an acute ischemia. We're not talking about like occlusion of femoral artery. We just talk about Steele syndrome, you know. And the same like the arm. If you do AV fistula, you get a Steele. If it's not affecting her motor function, always we treat it conservatively, you know, with exercise and everything. And the same here. As far as she has motor, you see, I do a motor function. If the motor function is intact, sensation is intact, she has a signals in DB and BT, I can wait, you know. But if it's severe to the point she cannot move her finger, her toes, she can move her leg, of course, different. Then you have to interfere, you know. All right?
Yes.
Okay, exam has changed to bulbal pulses and monophysic signals. What is that? The exam has changed to palpable femoral pulse and monophysic signals, pedal signals. EBI 0.4 to demonstrate widely patent femoral vessels and cross bypass. There's 2 and 4 flow in the proximal SFA with mid-SFA occlusion. How to interpret this finding? What do you do about it? What doesn't normalize? Talking about, so they order the ultrasound.
Steele syndrome.
That the bypass is open, but this drop, you know, the same what we talk about it. We try first to wait.
Observe, yes.
Observe. It's not normalized. Normalized, you know, you try conserve measurement, did not work. Then you do interventions, okay?
Okay.
Finish. All right. Good. You guys, all of you will pass. Don't worry. Just relax for the exam, okay?
Thank you. Thank you.
Number 5. Who is going to take it? Rafa, do you want to take number 5?
Yes, please.
Okay, go ahead.
55 years old man with the type 2 diabetes mellitus presented to the clinic with the right plantar foot ulcer that has been presented for a few months with some associated drainage. He has past medical history of medical treatment, coronary artery disease, and mild COPD. He has never had major operation, still smoking, half packet per day, and take it daily aspirin and high dose of statin.
Okay, so diabetes, smokers, he has right foot ulcers, coronary artery disease, COPD. Looks not a good patient, but he already on aspirin and statin. So the
Yes.
question must be the same question, what you do next?
I will start it by history and physical examination. From the history of the pain when it started and the wound, and if there is any history of, he already mentioned diabetes, hypertensive, risk factor, diabetes, hypertensive, hyperlipidemia, or the smoking he mentioned, and about the history of the cardiac disease, history of infection, history of trauma, uh, similar attack, any intervention was done before, uh, and also about if there is any history of claudication or wrist pain.
Okay. And then after that, after all history, what you do?
Examination for the neuromotor and vascular assessment, and localize the ulcer about if there is any infection, sign of infection, erythema, pus, drainage, and the palpable pulse or not, comparing to another side.
So he did that. So he does not have calf, claudication, or wrist pain. He denies chest pain or shortness of breath with ambulation. Rather, he has bubble femoral popliteal pulse with monophasic pedal signals. There's an ulcer on the plantar first metatarsal head with some focal erythema without streaking erythema or crepitance. Notably, he also has a lack of protective sensation to both feet in the stocking glove distribution. What other tests would you do?
I will start it to duplex arterial ultrasound and API,
Correct. What else? Remember,
and
this one has
X-ray
also
X-ray for the foot,
what you're looking for.
for any history, any gases, sign of infection, gases or stomatitis.
Correct. So you do both. So you're going to address both. We have an ulcer, so you have visual infection, plus you want to do the arterial flow to the foot. So WBC is 100, CRPs are mildly elevated, EBGs are 1.4 bilaterally, toe pressure is 0.30 on the right, 60 on the left, X-ray negative for any fracture or gas. How would you interrupt this finding? What you do next?
First, I will admit the patient, keep the patient on IV antibiotic, culture, wound culture, and wound care of the patient, and
But why we admit to our service? His EBI is normal. We should, I think, emergency room that call medicine admit him. Why should we admit him as a vascular? His EBI is normal.
it, it is where is it normal? API is 1.4.
Oh,
This,
bilaterally.
yeah, this is due to the diabetes or atherosclerosis diseased vessels.
When a disease vessel, EBI go down, doesn't go up. When you have disease vessel, they go down, right? It becomes 0.7, 0.4, but 1.4, almost like above normal, usually 1.2, but still for me, it looks normal to me. What do we call
Yeah.
that? You're there, we're just not getting it, but you're there. It's called false positive, correct?
False positive, yes.
Yeah. Why is that? Because calcification, not atherosclerotic disease. No, atherosclerotic disease, nothing to do with that. Because calcification, because diabetic people all see calcification. So when you get a high ABI, but with a low toe pressure, there's a reason why they toe pressure. So when you have a false positive ABI, you go to do toe pressure because it's very rare to see calcification in the digital arteries. And you can see in the toe pressure is 30 on the right, and the left is almost normal 60, you know. So this tells you that then you do TBI. TBI is abnormal. So anytime you see false positive EBI, you go to TBI. And it's very obvious here, he has a significant drop in the TBI on the left foot, which consisting with history that. And you do an X-ray to looking for fracture gas, I agree with that. So as you said, you admit him. So you started on antibiotics, you did arterial duplex, and this is what showed. So what would be your next step?
For angio endovascular for diagnostic and proceed.
Okay, you can do that. I have no issue with that. Why don't get CT angiogram?
Because it's palpable, femoral and popliteal is
Okay.
Mainly the tibial
Tibial. You want to see
spaces.
tibial artery. We don't get CT angiogram to see the tibial artery.
It's better for to see by endovascular for diagnostic, and it's low risk of uh, kidney injury, or due to the contrast, we'll use it the low amount of the contrast.
Yeah, but his kidney is normal, and I'm not concerned about his kidney. His GFR is normal. So why don't go do CT angiogram?
Another leg is palpable. It is only the tibial vessels. It's better to the selected and diagnostic to proceed.
Okay, so this is correct. So you just tell me because his has femoral popliteal are palpable, so most of his disease at the tibial level, and tibial disease, the artery is very poor visualized by CT angiogram because of the calcifications, you know. Especially has a high ABI, that means has a calcification because it has host positive. The reason why CT angiogram will not be very helpful is the way you answer. So we will proceed with the angiogram and interventions, okay? You did an X-ray to rule out osteomyelitis. Does the X-ray alone can rule out osteomyelitis? Is the WBC 11?
No, it's better to do by MRI.
So some people, they do an MRI, okay, to rule it out. All right, so the MRI is no abscess, saphenous vein 3.35 throughout the right, 2 millimeters through the left. What is your goal of your angiogram? What you plan to do an angiogram? Yeah, why doing angiogram? For what?
For diagnostic and treatment, if we can treat it.
Endovascularly, correct. That's it. And guys, don't think the question is tricky. Just answer real. Yeah. Why doing angiogram? To diagnose, because I want to see how the tibial artery below the knee, because I cannot see them well on CT angiogram. And same time to see if any stenosis, I can address it to increase blood flow so the ulcer can heal. Okay. Angiogram demonstrate inline flow to the right below the knee popliteal, which we're expecting because he has a pulses. But the anterior tibia and posterior tibial artery are occluded proximally, both with reconstitution in the mid calf. How would you address this finding? Yeah, what do you do?
I will try to do angioplasty ballooning for anterior cannulated anterior or posterior. If failed, I
Why
will.
is it or not both?
Yeah, even both.
It is the exam. See, so yes, I try to do open both if I can. If I cannot, at least I try to open one. You know, but my
Yes.
aim is to see to open both if I can. Okay, this might be my plan to go into vascular, right? Do you prefer to go surgery first?
The patient, he needed to correct the outflow because the problem there is the wound, and if failed by endovascular, I will do surgery next.
Okay, why don't go surgery right away?
Because already the patient on the table for that diagnostic endovascular, I do it for him.
Okay, if I go with surgery, this is something wrong, you think?
No.
Okay, this is an option. So you tell him, yes, it's an option. You can go right away, but I prefer to go with endovascular, less invasive first. The second thing is the patient is very sick. If you remember when we start, he has coronary artery disease, he has COPDs, you know. So I prefer to go with endovascular, you know. Then we have a couple of trials, like, you know, Basil, we have Basil I and have Basil trial, Basil 2 showed that endovascular, you know, like in this scenario could be, you know, your first choice. But you can go
Yes.
either way. So your way you discuss it, you know. But as you said, I already tibial, I'll try to recannulate it, especially a sick patient. So I prefer to go with that and leave surgery as backup. But if somebody want to do surgery right away, I cannot fail him for that. I mean, it's his options, you know. All right. All right, you are unable to cross the anterior tibial occlusion, but you are able to cross the posterior tibial occlusion. How would you treat it? How you treat after you cross it? What do you do?
I will plan to do a surgery for the patient bypass.
No, no, no.
For
Rafat, look at the question. Be careful of the question. I said you're unable to cross the anterior tibial, but you're able to cross the posterior tibial. How would you treat it? They mean how you treat the posterior tibial, not the patient. Treat it.
By ballooning.
Yeah, you see. So pay attention to the question. Yeah, you're just ballooning. You know.
Yeah.
What usually size balloon usually used in these arteries?
3, 2 to 3.
3, 2.5 to 3 usually in
Yes.
arteries. Okay. All right. You're ballooning, but now you have a flow-limiting dissection at the distal posterior tibial artery. How would you manage it?
By stenting.
By stenting. Okay, so let's now tell me what kind of stent, what the length of the stent, and what type of stent.
Really, I
Did you ever
didn't
stent
use it.
the tibial arteries?
I didn't use it.
Then don't do it. If you didn't do it, then don't mention it. If you don't do it, no, we don't. Rarely we stent but because I tell you why. Because in the tibial artery, you need a self-expandable stent. You're very small, like 3, or 4. And stent, they don't work very tibial artery because they're already calcified artery, already diseased artery, small artery. And you need a long stent. So the patency is very poor, really. So rarely we stent the tibial artery. If we stent, most of it like localized, short, and most of the time you use balloon expandable, drug-coated stent if you want a good result. Any other stent, they don't work, I mean, you can argue sometimes you stent just for a couple months until the wound heals. You can argue about that. But in common practice, we don't stent. And all the guys who work with us, they saw rarely we almost never stent below the knee. So if you have a dissection, what other treatment for dissections?
Ballooning. Compression by ballooning.
Ballooning what? But just ballooning? We already ballooned it. Why you need to balloon it again?
No, just to keep it for a few minutes.
Correct. How many minutes?
5.
Correct. 5 minutes usually. So you call prolonged ballooning. This is what we call it. You just ballooning. You did ballooning. So we do a prolonged ballooning. You put a balloon and you put it there for 5 minutes. And most of the time it will solve your dissections. Okay, this is what usually we do. Your angiogram restored. So after you did that, showed a resolution of the dissection and inflow line to the foot. What is your discharge plan? Yeah.
Keep it the patient on antiplatelet and statin, wound care, and follow up the patient.
Okay, correct. Let's sit back and say you couldn't cross either, both, but so that the distal posterior tibial artery reconstitution at the medial malleolus with plantar branch filling the foot and intact pedal arch. What you do then?
If we cannot passing that, we do the surgery for the patient.
Correct. The surgery.
Bypass.
Your bypass. Okay. What kind of bypass?
For this patient, I will do popliteal to posterior below knee. By refers saphenous vein.
Okay. So you do popliteal. Okay, that's good. Why wouldn't you go from the groin? Why don't you do femoral pedal pulse? Posterior bypass. Why you went popliteal, not femoral?
Because it's patent.
Because they are patent.
Yeah.
The second thing is that which one patency? The shorter is the graft is the better patency, correct?
Better than the long.
Second thing, you don't have to cross the knee. So all that you go with that, to go with a shorter graft. Okay. Describe your procedure. So how you do it? And it's important, guys, because you have to know how to expose the tibial arteries for your incisions, and the same for popliteal. So we're going to go to posterior tibial, popliteal to posterior tibial. So where's your incision will be? Or you want to read it, guys, about it, and that's it. Should skip it.
Up to you.
Okay. So please read about it, guys. Bypass, you have to know the anatomy, where you incision, how you do your incision, how you expose the artery, how you tunnel it, you know. So you have to know that. Okay.
Okay.
What if there's no suitable vein for bypass?
Here the below-knee, better to use saphenous vein, titular vein.
But there's no vein.
I will use contralateral.
You can try contralateral. Let's say contralateral is no contralateral. What do you do?
Upper limb vein.
Upper limb vein. Okay. Well, let's say upper limb vein also is bad because he's the, you know, then what you use?
Umbilical.
No. Don't jump to this one, because if you see this one now, you see, sometimes if you don't say anything, it's better than say anything wrong, you know. You can use a graft. I mean, still, this is just for the wound, you know. If you stay open for 3-4 months, could be enough, you know. If you run out of your options, then just put a prosthetic. It's okay. It's not, you know, disasters. And you can argue, you can tell him, because I had no vein, no arm vein, no legs, no, you know. You can somebody argue why you don't use like autogenous vein, not autogenous vein. What's name? Of the cadaver. But you can say it's not available, and some people still can use a graft, but you have to be concerned about the infections because you deal with the infection ulcers, you know. But again, I mean, even if you use a graft, he can tell you patency is bad. He said, yes, I know patency is bad, but at least it can stay open for a couple months until the wound heals. And after that, even the graft is got occluded, I'm still fine. Okay?
Okay.
All right. Are you worried about the lower patency rate compared to, talk about the graft. Are you worried about the patency rate in the low compared with the saphenous vein?
I didn't remember the number, but is this
No,
lower?
is it concern? I mean, that the patency rate of the Gore-Tex, you know, are bad, or arm vein, and all of them really are bad, like, you know, cryo vein, arm vein. So let's put it back, guys, and so let's make it this question. The first option, you'll be epicentral vein, okay? Get the saphenous vein. Second option, you can use the short saphenous vein also, okay? If it's not available, you go contralateral vein, either greater or you know, lesser saphenous vein. Sometimes you can get two pieces, and you can suture them together. So you try to stay in the leg as much as you can. If you cannot, then my second option will be the arm vein. Okay. Arm vein doesn't work, then my third option will be the cryo vein. Cryo vein is not available, then I can use prosthetic just to get the patient over the healing process or healing period. But this is the way you approach him, you know, in the exam. So try to stay in the leg as much as you can. If you cannot, you go to the arm. If you cannot, then cryo reserve vein. Even cryo reserve vein, its patency is very poor, really. But it could be an option. But if you don't have it, then I'll use prosthetics. All right. Any question about this case before we move?
No, thank you.
Bassam, Muhammad? No.
It's okay.
Okay.
واضح.
Muhammad, you want to take this case? Back to you, right?
Yes. Yes. 45 years old man with no prior medical history admitted to the intensive care unit with COVID pneumonia. On round, the patient endorsed severe leg pain, and the team cannot find any pulse. After initiation of the heparin drip, vascular surgery is called to evaluate the patient concern of acute limb ischemia. By the time you see him, it has been already 6 hours since the onset of the symptoms.
Okay. So most probably what you do next, same. What's the question?
So what do you do? I will start also with history and examination. And focusing on the...
Ahmed, what the most important things in the exam and in history you want to know about it? What about in your mind you want to differentiate between two things? What are two major things?
Two major things. I will make sure. I will check how is the patient condition, is he stable, unstable, for any intervention, and they will do a full vascular examination.
No, Muhammad, you didn't get my question. My
Mm.
question, back in your mind, you have two things. I want to differentiate between them. So I
Thrombosis or embolectomy, or embolus.
say that again.
Is he thrombosed or embolus from the somewhere else? Yeah.
So is this an acute on chronic or is it an acute pure acute? This is the main
yes.
thing in my brain. You know, is that
Yes.
for because treatment can be different. So
Yes.
in my brain, I'm thinking, is this an acute on chronic or an acute? The reason why
Yes.
all my questions go toward this, even my exam should be toward this too, so I can differentiate. This is what you'll be and you're asking. So how you can differentiate between your questions?
So I will I'll ask peripheral any peripheral vascular history before diabetes mellitus, hypertension, coronary artery disease or stroke, and this is in the question. Or AFib, is he having AFib? Is he on blood thinner?
Okay.
Does he have any intervention by vascular team before? So
Okay.
this is the kind of question I will ask him.
An exam.
On examination, I will compare the right to the left. So if he has normal and the contralateral side pulse all over, that will give me an idea. This is mainly acute event coming most likely embolic to or due to his condition.
That's good. So it's the most
Yeah.
important. So I ask him,
Yeah.
have any vascular history? Do they have any claudication? Does they have any wrist pain? Do they have any ulcer before? Any intervention, as you said? And physical exam, see how the other leg. If the other leg completely normal, then yes, you may think about embolectomy. Because it's very important to differentiate between both, okay? So let's say there's no prior history of claudication. The pain has been constant for the last 6 hours. He's young guy, he's 45. He has palpable pulses throughout the left and absent pulse on the right. Decreased motor and sensation. There's a faint monophasic posterior tibial signals on the right. What will you do next?
So he's now acute Rutherford 2B. The best thing that I have to take him for embolectomy.
Ahmed, it's good answers, but if you told me Reserve 2B, which is first, I didn't ask you what is.
Okay.
Just be sure that you know them, because you say, about Rutherford classifications, you know.
Yeah.
You just want to be sure that you know if you decide. So if you decide to make, because I didn't ask you what, you can tell me just an acute ischemia. I didn't ask what the Rutherford classification. But if you volunteer, you want me information, just be ready, just in case he asks you, okay, what are Rutherford? Why is 2B, you know? Just you should, you know. If you don't know them, don't mention it, okay?
No, I know them, yes.
Can I teach you tricks? This is the way you can pass. Tricks.
Thank you so much. I know. I don't want to get in trouble.
All right. So he has an acute ischemia. So what are you going to do next?
So acute ischemia, limb threatening. I will take him for embolectomy immediately to OR because we're already late 6 hours. I will take him immediately to the OR for embolectomy and possible fasciotomy and possible diagnostic angiogram at the end.
Why didn't you get CT angiogram?
It's already late and the patient is 2B. I don't want him to go for any further damage.
I mean, a CT angiogram can be done in half an hour. By the time they are ready, getting the CT angiogram. Okay. So what do you think? No, I'm just asking. I'm not saying it's the right or
because it's confined to one limb. I have normal other limb on the other side. My examination is clear, and for acute limb ischemia, it's time-sensitive procedure can be dealt with history and examination too, and they can do diagnostic in the OR after I finish.
What if somebody got CT angiogram? Is that normal?
No, it's not wrong. It's not wrong. If I can get a CT angiogram very fast, yes, but I don't want to delay the patient for further damage while he's very young.
Okay. I mean, you can argue both way again. I agree, CT angiogram, I don't think going to add more information, as you said. You just delay the procedure because the other arm other leg has a pulses. If there's no pulse in the other leg, then I have to
do it.
I don't know what the level of the aorta is, just suprarenal, infrarenals, does he have an
Yes.
aneurysms, then you have
Yes.
to get, but and if he has an acute or a chronic, then you have to get it because you don't know how his aorta looks. Even if you have a pulse, you may have like a disease aorta. So then you have to do it, But as acute ischemia and no previous history, I think, as you said, physical exam would be enough for me. But again, some people they argue no, should do CT angiograms because you do a duplex, I have no issue, but I don't think so. And this is what he did his CT angiogram here, which is the reason I don't agree with him. I don't think he needs CT angiogram. It's very clear. Just take him. But anyways, they did a CTA and demonstrate thrombosis of the right common femoral artery, opacity, opacification of the SFA and occlusion of the popliteal artery and crural vessels. What your interpretation of the imaging and plan for treatment of the patient? Before you go, I think you can argue about CTA if you're not doing intraoperative angiogram. If your facility cannot do it, then it's better to get CT angiogram so you know where clot and how much you can take a clot.
But
if
I
you have
mentioned,
facility,
yeah.
I think angiogram should be thrombectomy. But again, some people they may argue no, CT angiogram can show you how distal, like his popliteal is occluded, how's the tibial artery. So you can go either way, really. I mean, you cannot say it's wrong. So it depends how situation, how urgent you feel about these patients. But if you decide to go without CTA, then you have to do on-table angiogram. Because we don't rely on back reading alone. It's not enough,
Sure.
But if the CT angiogram show me only common femoral artery occlusion and everything's open, then I don't have to do an angiogram. I just do open thrombectomy. I'm out of it. So this is the advantage and disadvantage of CTA. You see, this is the way you have to argue about it. So if you have a facility, you can do an open on-table angiogram. I don't think CTA is important. If you don't have this facility, I think CTA is important before. All right. So what your plan of treatment? As you said, you're going to
open
surgery.
and they will add in the consent now possible popliteal embolectomy, another incision for popliteal embolectomy.
Usually we don't know, so you just write all necessary procedures. Usually we say, or you just write omethrombectomy of lower extremity arteries. We don't specify. So describe your surgery. Popliteal, SFA, and common femoral.
Okay. I'll make sure the patient's still on heparin infusion. I will get a groin exposure with a longitudinal incision. Identify the inguinal ligament, opening the common femoral sheath, get a proximal control vessel loop around it, and distal control over the profunda SFA, and I will bolus the heparin. Then with 11 blade and both scissor, I will open the longitudinal arteriotomy or transverse arteriotomy, and I'll start to do embolectomy using Fogarty catheter. I will get a good back bleeding.
What the size?
I will start for the proximal by 4 and 5, and for distal I will start with 3 and 4.
Just a second.
To popliteal.
You said, how do you mean by proximal?
To the iliac, I will start.
Why with the iliac? They didn't. Nobody mentioned about iliac. Did they mention?
Sorry. If I have good gush of blood from proximal, I don't do.
You don't need to go to Fogarty. You may damage the artery. Because you only have common femoral. So inflow, no. So you only have to consider on outflow.
Yes. So outflow, I will use 3 and 4 and make sure I don't cross the popliteal in the first passage, first few passage. Then I have to expose the popliteal. I will do a diagnostic angiogram if I have, or if I don't have in my facility, I will open the popliteal below the knee and get the trifurcation and do selective embolectomy to the three crural vessels through medial approach below knee.
Okay. Can you do embolectomy for the crural vessels from above?
I can do, but most of the time I need it will go to the peroneal artery, and it will be very difficult to select unless I have a diagnostic angiogram or on wire Fogarty.
Okay, this is correct. So the reason why anytime you see popliteal artery occlusion with a crural, I prefer you have to go open below the knee. You know.
Yeah.
Now you can argue that below the knee it has to be open. The groin, I think, for me is controversial. Unless if I'm worried about the profunda, because you can do embolectomy from below. I'll look at that, you know.
Yeah.
But you do both. I have no issue with that, you know. But you have to open the popliteal arteries, you know. You see, if it's only space occluded and popliteal and crural, I think I do all the procedure from below. When the common femoral artery is occluded also, then I think I will go both because I'm worried about the profunda, you know. If I do down, it's hard to do. I'm afraid the clot can go to profunda, you know.
Especially profunda is open in this case.
Huh?
And especially he didn't mention that the
It's open. You don't want to
yeah.
push the clot to it if you do thrombectomy. The reason why it's better to do one thrombectomy and be sure the profunda is open, you know.
Yes.
It's very easy to do from above. But if he come with SFA occlusion only and common and popliteal and profunda is open, just SFA, popliteal crural artery, then I'll do the whole procedure from below. Because when you have a crural artery occlusion, then I have to open below the knee. Then I have to think about the upper, do I need it or not? So if it's a common femoral is occluded, I think I'll open also both the up and lower. If the common femoral artery is open, just SFA, I think I can do everything from below. And you can do an angiogram from below. But the whole idea is that when you have a crural vessel occlusion, you have to open popliteal below the knee. Yes, you can do it from above, but you have to have a catheter and you have to have over the wire balloon Fogarty, which we don't have it most of the time. So the safest side, the best way just to do it from below the knee, open popliteal and do selective embolectomy, okay? They may ask you how to expose the crural artery. So you have to know how to expose it, you know. The most important to expose the anterior tibial is to ligate the tibial vein, anterior tibial vein. You have to
Anterior
ligate
tibial vein to open the
so you can push the
tibioperoneal
vein.
trunk.
Yeah, and then you get tibial peroneal trunk, and then you get posterior tibial peroneal arteries, you know. All right, so you did that. What if there is no pulse at the end of the case? Oof, what am I going to do? You're there?
Yes, doctor. Hi. He's a young patient, so I will do diagnostic angiogram, and I can, if there is no obvious thrombus I can retrieve, I will inject intraarterial babaverine or nitroglycerin.
Okay. Say that again. Sorry. Say that again. What you do?
Yeah, I will do diagnostic angiogram with the same puncture I have, and I will close the puncture site. I will go with the sheath. I will do diagnostic angiogram. If there is no obvious thrombus I can retrieve, he's young patient. He might have vasospasm after the procedure, so I will give him intraarterial nitroglycerin or babaverine.
And watch it.
Yeah, and watch it. Yeah.
Okay, it's reasonable, you know, as
Mm.
far as you don't, but you have to do the angiogram to see.
Yeah, yeah.
Just see
I
like
have to.
a table low flow, then yes,
Yeah.
could be just a spasm. But if you see like a clot or cut off, then
Yeah, I have to retrieve it. Yeah.
yeah, I am fine with that. Why would you not have a pulse if you clear all the clot? ليش ما بيجيك pulses sometimes?
Sometimes there's vasospasm, especially young patient, healthy arteries.
From the Fogarty.
Yeah.
How would you manage this patient postoperatively? What are you going to do postoperatively?
So I will keep him in heparin drip for a few days, and I will start investigation why he developed the thrombosis.
Okay.
So
you're
I
gonna
will,
anticoagulant. Yeah.
yeah. So I'll make sure that I have a full cardiac echo, and if he needs, we'll do transesophageal echo, we'll do CT chest,
Just a second.
and
Ahmed, you went too far.
Mm.
I don't understand. I say,
Yeah.
after surgery, how would you manage this patient? Why need an echo?
imagine heparin first.
That's it. Stop. Why you talking?
That's it.
Don't give
Yeah.
information. Too much information.
Okay. No, because انا عقلي معاه وش السبب اللي صار له ثرومبوسيس لازم
لا, don't volunteer information. Just go to the
Yeah.
question, answer it.
Okay.
خد معك للزيقة, عرفت كيف؟ لزق. Guys, don't get yourself to trouble. That's the question. Why was South Africa? I put him on anticoagulant, heparin, and just watch it for now.
Yeah.
And the most important, you watch for neuro. Did you do fasciotomy or not? I don't know. Did you do fasciotomy or not?
I consent him for fasciotomy. I will do it because it's more than 6 hours now.
You did or the prophylactic fasciotomy?
Yeah. Yes.
Patient does well, but 3 months later, he show up to the clinic with a small wound on his great toe. His EBI dropped from 0.9 to 0.5 since your operation. Right. So what do you do next?
I'll make sure that he's medically optimized on oral anticoagulation. I will take more history and examination what happens during this month, and how is his functional, what his symptoms. After that, I'll do full vascular exam. Then I will send him for ultrasound with duplex.
Okay. But you already did the duplex. Is that the reason why ABI came back 0.9? I mean, imagine it's already the duplex.
Okay.
All right. Why didn't do CTA?
Yeah. So if I did the duplex and it's not informative because I cannot I don't know about the waveform and the velocity here, so I will order CTA again.
Okay. Angiogram showed. I know they keep doing angiogram. This I think. By the way, in the state, I know they do a lot of angiogram. They don't do CTA because of money reason. I don't know why, but really
it's in here and in state doctor الCT الماني يروح للراديولوجيست. But if you do ultrasound ايوه الالتراساوند تروح للفاسكولار لاب للفاسكولار سيرجن والانجيوجرام تروح للفاسكولار سيرجن. فهذه بس.
Guys, even when I go to state, when I do, because I go practice there, I see they do angiogram. Rarely I see them do CTA.
يا قليل مرة هنا كأنه حرام الCT.
That's why in this question they keep going to angiogram. Anyway, let's say CTA showed long segment distal FA and popliteal artery thrombosis, reconstitution of posterior tibial artery at the mid calf. What do you manage it? So now he came after 3 months. He has an ulcer. He's a young guy, and now he's SFA, long SFA and popliteal artery thrombosis, saccharomaratani, with reconstitution of posterior tibial artery at the mid calf. How would you manage this patient?
So he's still young. I'll make sure he's medically optimized. I will send him for vein mapping.
What do you plan?
Vein mapping depend on the vein he has. If he has a good vein, I will take him for femoral to distal bypass to the BT below the knee.
Why don't do in the vascular?
A very long segment thrombosis, so the risk also of showering is still high. So I'm in favor of, and he's still young, so I'm in favor of doing open, to be honest.
How you do open thrombectomy again? Because it's been 3 months. It's not an acute, correct?
Yeah.
We don't know.
Yeah, it's not an acute. Sorry, yeah, it's not an acute, and he had ulcer. Yeah, sure.
So you have to have
قاعد
3
أشوف
months. So
المدة بس. Yeah,
don't
you need
know.
at least
Now
2
has a
weeks
wound.
and more. Yeah.
Right.
And
So it has the wound. That means it's been included for a while now. That's the reason why you
Yes.
develop a wound. So it's been chronic.
Yeah.
So I will not try it. And second thing, you already thrombectomy. So why the second time is going to work and thrombose? So that means his artery is already like in the thrombogenics. So
Yeah.
I'll not try that.
Yeah. Now is it okay to send for like a thrombosis test? Why he thrombosed? Like I'll do
Remember,
full
he's a COVID.
thrombophilia. Yeah. Before I
You
do
don't
the
need that. Yes, you can do that, but remember, he's a COVID. The reason why so he's hypercoagulable anyway. So I think he has to be for good time, you know. And because poverty artery is occluded and SFA is occluded both long, I agree. Surgery, I think, is much better than goes endovascular. So I just look at for the vein, and then we send it for vein mapping, and mostly I plan for bypass.
Yes.
All right, so vein mapping short form, you take SMS on both lower extremity, describe your operation. We don't have to go through it, you know.
Yeah.
You just have to know where, how to expose the posterior artery. Again, guys, just have to know the technical part, where you do your incisions, you know, what you find after you cut the skin, subcutaneous tissue, fascia. Yeah, then you find poverty artery, where your incisions, you know. So you have to know that. As I said, oral exam is more about technique. You see, guys, all the exam we do together, rarely we have any informations, you know, all more like practical, how you think and how you use your information in the real life. You see, is none of the question what the percentage like patency rate of saphenous vein versus prostatic for below the knee, you know? What percent? We don't ask this question because not what the name of the trial, we don't ask it. You see, all like practical question. You are in the clinic, you see what the patient you see. We want you to know how you're going to deal with this patient when you go to be, you know, in practice, like hopefully after the exam. All right, so if the patient did not have adequate vein or to reach, we talk about it, then you have to go to the other one. We talk about it before. But if there is no vein available and the vascular option have been exhausted, then what are you going to do?
I'll do, I will go to the contralateral limb. I can sew both GSV outside the patient, and they connect them together. Then I do.
No, but as I said, Muhammad, as I said, no vein available. That means
no vein available. What if there is no vein available? Sorry, because two different
so that's
questions.
it. An option is no endovascular. So what else you do?
Endovascular, I will go. I will go no vein, no endovascular. I'll go with the with the synthetic graft.
Yeah, that's it. It was a GF we talk about because it was a cortex graft. Yeah. Okay, what's the vein? You see, this you have to mention that when you do cortex, I forgot to mention that last time. When you do a cortex patch for below the knee, you have to do a vein patch.
Yes.
Right. What different of vein patch we have? We have 4 technique. You know what they may ask you this question.
Yeah. So I forgot the name on capital batch. Yeah.
Taylor, one of them is a Taylor patch.
Taylor batch, yeah.
Okay.
Taylor batch is mainly you put the vein batch, that like an endarterectomy vein batch, then you put the graft over this vein batch, over the vein opening.
I'm going to show you guys the picture because it was important to look at that. New share. Let me see if I can find it. Yeah, here we are.
معلق الكمبيوتر دكتور فتح
لانه انا احاول اعمل لكم شير where is the screen share? Here we are. You see it now?
Yeah.
So this is our okay, you see it now?
Yes, doctor, clear.
So this is the Taylor patch. This is what I use. The one I like it really the most, the Taylor patch. You know, so what happened when you do that, you get your graft here and you do the posterior V. Do the anastomosis here, you know?
Yeah.
And then you cut it this way, this graft, and then you put a patch here. It's called a Taylor, because most problem happens that this anastomosis here. So you want to put patch on this area. This one hardly get any here. So most probably at the toe, not the heel of the anastomosis. So after you do your V here, then you cut the graft this way, and then you put your patch here. Linton patch, you put like a regular patch and then put a graft on the patch. So you have artery, vein, and they have a graft, okay? Miller cuff is just you make the vein like a cuff. So this is a vein, this is the artery, this is a vein, and this is a prosthetic. So you have a vein between the graft and the artery. And St. Mary, I don't know, I never use it. Looks like the same. They just put the vein around it, you know? I don't know about this one. But I found the easiest way, either you put a patch like Linton patch or Taylor patch. I think Miller cuff is a bit more complicated, more difficult. I will, but you have to know about this for technique in case they ask about in the exam, okay? Any question about them before we go back? No. All right, so let's go back to our lectures. Sharing screen. Share. All right, so what are the other adjuvant maneuver can be performed to accomplish the same goal? We talk about the other patch. You see the screen now?
Yes, doctor. Yeah.
Yes,
Yes.
We talk about vein patch. If you don't have vein patch, then you can use a Miller cuff.
Yeah.
You can use the other patch, you know. You can put it in, put the graft on it. So you have to know about it.
Pericardial patch and Miller cuff.
No, not pericardial. All vein patch.
Okay. Okay.
Yeah. Always use a vein because the whole idea you need something soft. You need something, you know, soft because all problem happens at this anastomosis. So you want to put a vein at this area. So, but don't do composite vein. It's not good. Composite they don't work. Like half vein and half graft, they don't work for some reason.
Okay.
So you just go there and you put a patch, or you put patch on the artery, you put the graft above it, or you do Taylor patch, or you do the cuff. Taylor cuff.
Mm.
All right, number 7. I think we almost said. You want to continue, guys?
Yeah, one more, doctor.
All right, we are going to
This is
Bassam or Bassam, right? Go back
Yeah,
to you. Okay, go ahead.
ماشي. بسم الله الرحمن الرحيم. A 68-year-old man who underwent an bifemoral artery bypass 5 years ago for claudication presents to the clinic for his yearly follow-up. Over the past 2 weeks, he states that he has been having fevers and night sweats. Okay, the right groin is erythematous, tender to palpation, and there is a small open wound over the scar that is draining a murky fluid.
What do you think is going on, Bassam?
So I think there is infected limb of
Correct.
the aorta bifurcation graft.
Correct. This is what we think. So what do you do next?
We'll elaborate more on the history and we'll do proper examination. History important when the onset, the
Okay, so you go through same things. Okay, let's move it from time. There's no
yeah.
history of other groin issue before or weight loss, and he denied claudication or symptom of CLI.
Mhm.
His abdomen is non-tender. The right groin has erythema, tenderness, murky drainage. There are bubble pedal pulse battery. What you concerned about?
Infected graft in the right groin.
That's it. Stop. This, you
Yeah.
have graft the right groin. So what it says. You're not concerned about thrombosis because she has good pulses, correct?
Yeah,
So
sure.
what work have you would you confirm you're suspicious?
I will do blood investigation, including blood culture, CRP, ESR, CBC.
Okay.
Also, we need to take culture from the discharge, from the drainage.
Any else things?
We can do WB
What
scan.
do?
I will do WB scan to rule out and to assess the extension of the infection.
Okay, so you can do WBC scan. Okay. which I agree with that. But in real life, what else you do? When patient come to our clinic like this patient, what are going to do? Before WBC scan, what we do? Do CT angiogram, right? Even if the graft is open, you have to see where's the fluid around it. Is the only the limb, the graft is a fluid around it, or the whole graft? Is any gas or is no gas? You know. So usually we need to order CT angiogram. This is the first thing we order. You know. So we order CT angiogram to look, see how bad the infections, where's the fluid around the whole graft, or just a limb which is confined to the groin. And then after that, we'll decide to go with the WBC scan or not. You know.
Okay.
All right, so you did lab, WBC came 16,000, CRP and ES are elevated, normal PMB, blood pressure bending, CT showed stranding and fluid around the right femoral anastomosis with intact flow in the graft and beta distal runoff. What you do like to do next?
Investigation or intervention? Investigation, we have to do. I think it's better to do WB scan.
We already have, you know, that's an infection. Why you want to do the scan?
Okay. So I will start him on IV antibiotics.
Okay.
Empirically.
Okay.
And I will prepare him for surgery. I will prepare him. I will do ECG, chest X-ray, echo, and to prepare him to check the fitness.
Okay, I mean, your first answer was correct, Sam. You have to do a PET scan. I know why you changed your mind. But why you want to do it, even CTA, because we want to know if the whole graft is infected or we're just dealing with the groin. It's very important to decide how our plan, correct?
Yeah.
Because CTA, it doesn't tell me if there's no fluid around the graft, doesn't mean the graft is not infected, correct?
Yeah.
Because, so we need to get a WBC scan to see if the whole graft is lighting up or only the groin. If we are dealing only with the groin, the treatment is completely different. If we see the whole graft lighting up, then they have to remove the graft, then it's a different story. So there will be a CT scan. It's good to should see the anatomy, where's the fluid, you know, how extended is the fluid, how bad is the inflammation. But for the whole graft to confirm it or rule it out, we have to do a PET scan. So after that CTA, I will do a PET scan. Okay.
Okay.
PET scan isolated infection to the right groin. What are the most common organism led to the graft infection? Yeah, this is the only time they ask you like a medical question. What the most organism you see it?
Staph epidermidis.
Okay, staph epidermis or staph aureus, right?
No, staph
What
aureus.
else? The most other things? The bad one.
E. coli, Pseudomonas.
E. coli is the most common. Yeah, is the other one. Okay. So did one doctor came back, staph aureus, what you plan? Staph aureus is not bad really. So what you plan?
I will prepare him for surgery, for resection of the groin. And okay.
So you're planning to take him for surgery to resect graft?
We'll resect the the groin part.
Okay.
And we'll do irrigation, debridement of the infected parts. Then we can do extra anatomical.
Okay.
Or use interposition venous graft.
Okay. Okay. Let's see what the question. Cardiac or negative, describe your operations. So what going to do? Am I going to use a vein graft? You're going to do anatomical bypass? What do you plan?
We can do, I will do venous mapping to check the great saphenous vein if available. And I will prepare the patient for surgery, prep and drape the groins. Then we'll open the groin longitudinally. We'll control the limb, the graft limb, and the native artery, proximal and distal, SFA, profunda, and common femoral artery. Then we'll wash with antibiotics, give heparin therapeutic dose, clamp the graft, resect the infected part, and if the grade 7 vein is available, we can use it for interposition graft. Otherwise, we have other options like bovine patch. We can make it like tube or extra anatomic bypass.
Okay. You see, when I describe your operations, that means you already made your mind. So you're going to surgery with one option only. This should be option before surgery. You go so and so. But when I tell you describe the operation, that means you gave me one plan. I want to explain how you do this one, any of them, you know.
Yes.
In general, vein graft or even bovine patch is not good because you have to cross the inguinal ligament because you have to take part of this limb, you know.
Yeah.
And vein crossing the inguinal ligament with the vein is not good because can be very easy or compressed, you know. Unless we're going to stay only in below the inguinal, yes, then a vein I think is a good options. But if you have to go higher, you know, under the inguinal ligament, I prefer not to do it and do extranatomical bypass. Okay, so you can argue this way why you want to do either way. So if you decide with the vein graft, as you said, you just put it there, and you suture to the SFA or to the profunda. And how kind of anastomosis, end to end or end to side with the graft?
With the graft, it's better to do end to end to the graft.
Correct.
And I will anastomose it to the SFA and reimplant the profunda.
Correct. This is a good option, yes. But again, this is presuming I think you are under the inguinal ligament, okay? If you
Yes.
have to go higher, then extranatomical bypass would be better options. Well, how extranatomical bypass, how you do it?
We can go retroperitoneal to expose the limb, the right limb of the graft,
Correct.
and use the vein or
No, don't
graft.
use the vein. Why you keep using the vein?
Okay.
Extranatomical bypass, always we use a graft. Vein only if you decide to put it inside. Because vein is a problem. See now, when you think about the groin area, joint area, all they can kink, you know. I mean, you can use it. I'm not argue, but will not be my first option. Go ahead.
Yeah, we can. I will control the limb proximally and use graft, then go through the obturator foramen to the distal SFA, and ligate the other parts like distal graft
So
and the
just tell me
profunda.
what your first incision will be. Where is the first incision?
First incision, retroperitoneum.
Second incision.
Um, medial thigh.
Third incision.
After I perform the obturator, then it's better to close and then open the third incision على الgroin, on the groin, and remove the infected part and close the limb.
Okay.
And do the debridement.
All right. I mean, this is correct, but you see, I walk you through it, but you should tell me that by yourself. So it's first you do the clean procedure first.
Yes.
Because you were talking, I didn't know exactly which one, because it's important for me to know what you do first. So you do first the clean part. Well, as you said, you do the flank incision, medial thigh incision, you do your bypass through the foramen of foramen. Yeah, and then you go, and after you finish and close the wound, you close them completely.
Yes.
Then you open the groin and you take it and you ligate both. Okay, it's unacceptable. What do you do if you have initial plan on local explanation and revascularization and you counter parent fluid and you pour incorporated bypass limb during the retrograde exposure? What he's trying to tell you that you open peritoneal to do a bypass, and they found, you'd be surprised that you find that the whole limb is has a parent fluid and poorly incorporated bypass limb.
Yeah. Then I will prepare to resect the whole graft.
Okay. So how you do that?
Sorry, I mean the whole limb, the right limb, right side. And after irrigation, debridement, everything, I will close the wound. Then I will go extra anatomical like axillo uniform bypass.
Okay. I mean, the moment you get the whole limb is infected, that means the whole graft is infected already with Sam, you know. I don't think resecting the only limb will be enough, because when the whole limb is infected, the groin is different. When only the groin, I understand it. But when you go to tonia and you see the whole limb is infected, that means most probably the whole graft is infected. So it's better to go and take the whole graft out, you know. So the best way is just you convert it to the midline incision, you take the whole graft out, suture it, and do external umbilical bypass, as you said. Or you do inside too, depending which technique you like. But whatever technique you decide, then you have to know how to do it and describe to us how you do it. Okay?
Okay. Okay. So even if the PET scan or WB scan showed that the graft is not lightening up,
scenario, and it doesn't make sense, the scenario. No, as you said, if scan PET scan low can, PET scan negative, we should not see the prone fluid. Okay? But this is like a poor question, really. This is, I'm expecting that you go there without PET scan.
yeah,
Because if the PET scan, you did PET scan before, you should not have this surprise you find a fluid, you know, around the graft, correct?
yeah,
So the question is not very good questions, really. Because as you said, if his PET scan is negative, and you can argue, like, as I said, in the exam, you can argue. I'm not saying what you said is wrong. You can say, I already have flank incision. I don't have a consent for experimental laparotomy for resection anatomical bypass. Patient is sick. I will just do as you said. I just go and take it out and put a new bypass, you know. But here, as no, yeah, you can do extranatomical bypass. You go as high as possible and you suture it. And then maybe later on put an antibiotic, and later on I will watch him. If he gets worse, then I go take him for big surgery. So you can argue this way, I have no problem. As again, in the exam, as for you argue and make sense is no problems, you know. So you don't have always to tell the right, or you do the final procedures, you know. So you are there, you're surprised you find this one. Even you can tell me, okay, I'm surprised, I'm not prepared. Patient's too sick, he's not well prepared for surgery. I just take this limb, I put a new limb, you know, but maybe use, as you said, maybe use a bovine, you know, patch, make it like a tube. And then or use a vein and do bypass, or I use a graft to do external anatomical bypass. And then I close the abdomen, I'll give you antibiotic, I'll watch him. If he's still get infection later on, I always take him in more controlled situations and exercise the whole bypass and I do anatomical bypass. You see, this is the way you have to discuss with them, Sam.
okay.
All right, so it's just discussion, the way how you defend yourself, but you can go either way. I mean, as far you have a reason why you go this way, not the other way.
Okay.
All right, so patient eventually discharged after a prolonged hospital stay. He presented to emergency department 6 months later with fever, night sweat, and 20 meter. Over the last few months, CTA pseudaneurysm at the proximal anastomosis. What you going on? So what happened? I think they took the graft and they put an interposition inside the graft. Okay, and now he came back again with the infection again in the proximal anastomosis.
Yeah.
So what do you do now?
Okay, now I will decide to reoperate and remove the whole graft, close the stump. Before that, I will do axillo unifem bilaterally.
Okay.
So first procedure will start with the clean one. I will do axillo unifem bilaterally, and then we'll open later on. We'll open the abdomen transperitoneal and remove the whole graft. Close the stump into 3 layers, or 2 layers, or 3 layers with proline.
Okay, makes sense. PET scan light up the proximal anastomosis, blood culture. There's the PET scan. Staph aureus WBC 18 and appear quite frail. How would you bring quite frail? So you said you do extranatomical bypass. In the abdomen, the graft is incorporated, and you have a few millimeter of renal aorta left, but the tissue is friable. How would you close the proximal aortic stump?
Yeah, I will close it. طبعا هو the main issue is the renals now.
Right.
So either to do bypass to renals or just to close, and then the patient will end with renal failure.
Okay.
And
mean, first,
later on, we can come back for bypass to kidneys.
okay. I mean, first to do bypass, there's no place. We're going to bypass. You're closing the stump, so there's no place for bypass, right?
Yeah.
So I don't think bypass be an options. I mean, you just have to said you just what you use in real life. Well, you use a bludgeon, right? So usually you
Yeah.
have to use a bludgeon or any tissue you can get as much tissue around this area, and incorporate with your sutures, and try to suture as much as you can and use a bludgeon. Most of the time you can control it, But this is the way I will do that. So if you have only a few millimeter tissues of frabile, then I use a bludgeon, and I'll try to incorporate as much tissue around the aorta with my suture to control, have a good, stump closure. Okay.
Okay.
This is how would be your answers.
What about the renals?
bypass, huh?
What about the renal arteries? Yani, we'll do bypass to renal arteries at the
No, yeah,
same session?
because the stump is like you are still in the stump. But the only problem is fragile. They're not saying so. You're going to suture the stump, but because of the tissue is fragile or friable, then when you suture, the tissue can cut through it. You see my point? So you are still below the renals. So you
Okay.
just want to strengthen your suture. So either you get a bludgeon, pieces, or string piece of bludgeon and you suture it. But the most important, like when we do aorta by FEM, when we suture the aorta after aneurysm, we take as tissue as around, as you can find tissue around, take it with you.
Yeah.
Don't suture only the aorta to aorta. You take all tissue around, you can it with the aorta and you do bludgeon. And this mostly will control it,
Okay. Okay.
All right. If it's still not controlled, then yes, then I just go above the renal, because you have to get patient off the table. But I don't think you can get to these positions. All in our life, when we did these cases, we just get a bludgeon or the tissue around it, and you'll be fine. You control the bleeding.
Okay.
All right. Here's number 8. Still want to go, guys? Well, you had enough.
شوف الشباب.
Sam, Rafat, or Muhammad?
One more can be fine.
One
Yeah.
more. Okay.
Rafat? Yeah.
Some came back only 2. Let me see how many. But I think the last one 8 or 9. There are 9. Oh my gosh. Yeah, there are 9. So now number 8. Let me see what's about. See.
سؤال بسام. Ligation of the aorta, even if it's fragile, what can we do? قريت في كتاب انه ممكن you use the ligament of the spine and you just take it with the tensor lata and add some bledget and just pray, right?
Yes, this is what I said, Muhammad. It's all the tissue around,
Took everything, yes.
Yes.
And how any way I can decrease the chance of blowout or no? Other than yes. Okay.
The only way you can decrease it by putting in situ.
In situ implants and these things can work. Can I mention it in exam or no?
Which one? Say that again. Which one?
Like I coil from inside.
No,
later.
No,
nothing. Yeah, it's not good idea too. But
I saw one case. Patient they did the same and they coil it, the stump, but not because of the blow up, because he developed aortoenteric fistula. And they coil it and didn't stop, and then one of the coil went to the renal, because you're very close to the renal, then the renals occluded, so they lost one kidney. So I will not coil. No, it's a big stump. I don't think it will work, So again, the more idea, as you said, you get, because spine is just behind you, and the tissue is, the fascia is very strong in the spine, perispine, because the water is staying on the spine, as you know. So again, the whole idea is to get all the tissue around it, all the fascia, tissue, as Muhammad said, around it, and use a bludgeon. This is the whole idea. As much tissue around it you can with your suture. And so, but the most important, don't suture aorta to aorta. You have to be like tissue, aorta, bludgeon, and back, And sometimes you do 2 layers. You do running and then you do interrupted with a bludgeon. So you do first running and then you do second layer with interrupted, So this way you can it. Okay. A few months the right side bothering him. Let me see what this collagen chronic bilateral proximal cramping. This is was named entrapment syndrome flux. Let me see what's the last case. Used to French, initially hemostatic when this is a bleeding after hemostatic. This is a simple one. So let's talk about entrapment. I think the last case is about like, you know, after cardiac cath, you get a hematoma bleeding, how you deal with that. This is simple. So let's go to case number 8. Okay, our last case. Who's going to do it? Rafat, I think it's your turn. Or Muhammad, whoever want to do it.
No, me, please.
Okay, go ahead, Rafat, please.
Yeah, 23 years old man who was prior to a collegiate sprinter present to the clinic with the chronic bilateral proximal cuff cramping and the plantar foot paresthesia with the exercise. And he denied any history of the trauma symptoms at rest. He is a non-smoker. His symptoms have been worsening over the last few months with the right side bothering him more than the left side.
Okay. So Masal, what do you do next?
I will start it by the history. If there is in about the pain affected on the daily activity or the exercise increasing, if there is any history of the risk factor, diabetic, hypertensive, smoking, family history of the aneurysm, trauma, examination.
Patients that he is very limited in his ability to exercise, even walking up flight of stairs flare up his symptoms. If there is any prior illness or injury, exam has a bulky calf muscle bilaterally without tenderness to palpation or evidence of popliteal mass. There's no neuromotor deficit. The beta pulse are palpable, no digital petechia. What are you concerned about?
Popliteal entrapment syndrome.
Correct. All right. What workup you order?
First, I will start with API, duplex arterial, duplex ultrasound, and CTA.
Okay. Well, let's first say an ABI. Why need an ABI for?
Usually, the initial diagnostic in the vascular lab.
Yeah, but he has a pulses are palpable. You know, so I don't think that will help unless if you do what? After exercise, right? So if you do this rest ABI, because symptom come in after exercise, you know?
Yes.
So if you do it on rest, will not, you know, so you have to, when you send it, you have to order it with exercise. If you order it normal, ABI, I don't think you get any benefit. You come back normal, okay?
Yes.
And the same, if you're going to order a CTA, I would order it in extension and flexion position or MRI. Usually we do for this one MRI or MRA, better than CTA because you want to see the muscles. So, but the most important when you order it, you say in extension and flexion positions. Because if you do it in the rest, you will not see it. Okay, you don't see the compression.
Okay.
All right. So ABI normal at rest. You see after exercise drop to 0.6 the right, 0.7 the left. With complete recovery after 5 minutes. Resting posterior superficial compartment pressure are 15. What you do next?
MRI with the exercise, stress MRI.
Correct. MRI, what are you looking for?
Popliteal entrapment. The muscle, to see the anatomical and the muscle.
What exam structure code? So what the muscles? Now this is the only thing they can ask you about anatomical positions, and they must ask you what type of entrapment syndrome. So but what the muscle usually?
Medial head of the gastrocnemius muscle.
Correct. Right. But again, guys, you have to be prepared for different type because you know it's different type of entrapment syndrome. So you have to read about it, and I will read about it and keep it, you know, in case if they ask about what type of entrapment syndrome, you know, so you have to know about it. There's no obvious sign of structure of popliteal entrapment during the neutral imaging sequence, but forgot to perform the provocative maneuver. So what do you do? So what happened, you send it for MRA, and MRA, they did it, but they did were in the resting, they didn't do with the stress MRA. So how can we make the diagnosis now?
Angio with provocative maneuver.
Do you do an angiogram in what? What positions?
Dorsiflexure, plantarflexure.
Okay, so you have to do in both positions. Okay, so you do an
Yes.
angiogram to confirm that. So there is the marked lack of contrast feeling with active plantar flexion. How do you in both legs? So how do you interpret this finding?
Bilateral.
Did an angio, and the angio showed a cut of the contrast in active plantar fixation, right?
Yes.
So what does this mean?
That meaning functional popliteal entrapment.
Yeah, so it's entrapment syndrome, right?
Yes.
I know about function. What does that mean? I don't know if this is a term you use or not, but this confirmed that he has an entrapment syndrome, popliteal entrapment syndrome. Okay.
Yes.
So what are you gonna do? So he agreed. And you tell him you want to do a surgery because knowing the vascular option, right? For entrapment syndrome, you have to do a surgery. So describe the surgery. You have to know how to do a surgery.
Okay.
Have you saw
Okay.
any cases or no?
For me, one case is we do interposition graft.
With the position graft, you did right away. The position graft.
Yeah.
Okay. Not the posterior approach.
Posterior approach. Yes.
Why did the position graft? Why just not cut the muscle?
Because it's not functioning. Because due to the damage of the artery.
The artery was damaged already. Okay.
Yeah.
So at the time, I just cut the muscle. You don't have to fix the artery unless it's already damaged. So it's late, you know. But if it's not damaged, most probably this itself will improve his symptoms, you know. And I prefer to go, as you said, posterior. But here in the book, they went through lateral. They did a bypass. I don't know why, but it's the way they describe it. They went from lateral approach. But you can go both. But you have to read about this guy's approach. So you need to read about Travel syndrome, how you do it, how you open your incision, what muscle you found it, what muscle you're going to cut, you know, the name of the muscle. So what the nerve you see it there, what the vein, it's medial, lateral. So you have to really familiar yourself with this kind of procedures, okay?
Okay.
And what muscle you're going to cut? What are you going to cut when you go there?
Medial head of the gastrocnemius muscle.
Correct. You're going to cut the medial head of the gastrocnemius muscle. Okay. And what else you have to do? You have to release, like if you know thoracic outlet syndrome, the most important also to release the nerve. You be sure that everything is released. You know, be sure no tendon, nothing, fibers there. You know, so you have to, because some type of them could be just a fiber. It's not the head of the gastrocnemius muscle. So you have to know what type you are dealing with it. How do you follow up this patient?
Usually the duplex arterial ultrasound and API at the wrist and exercise.
Okay, so you follow up as normal. After a couple of months with EDI and physical exam. All right, after 1 month, he reports his symptoms have resolved in the treated site, and ABIS with exercise are normal on the right. The emission on the left, what you do next. So the right, he gets better. Now he has, again, problem with the left side. So what do you do next?
The same steps we started in the right side.
Yeah, you perform the
We
same.
do it in the left.
Let's rewind. Now on the MRI, there are muscle slip that appear to be impinging on the neurovascular bundle, and on angiogram, there is a greater than 50% loss of the radial artery on the resting position, absence of flow and the proper type. What you do then? Okay, they changed it now. They said the muscle slip, and the 50% stenosis of the radial artery in the resting. So you have damage to the radial artery now, correct?
Yes.
Stenosis. Okay.
We'll do interposition graft in this patient.
Okay.
Or bypass.
You can argue on that. I have no problem. See, if you tell me I do angioplasty also, I may not also argue with that. You know, after a release, I maybe go from the groin and do an angiogram and look. If it's something simple, I can do balloon it. Maybe it work. If it's not, if it's a short, maybe end to end, and it's supposed to be better, especially in the posterior approach. If it's a short occlusion or stenosis, maybe cut it and put them back together. If it's not, then a bypass. So all option is good as far you explain why you want to do this one. You see, the way I talk is the way, guys, you want to talk in the exam. You know, I'll do so or so or so. All right, I think that's all. Yeah. So any questions, guys, about lower extremities? Any concern?
يعطيك العافية. تسلم. شكرا شكرا دكتور سامر.
No problem, Rafat. What are you going to do for tomorrow?
تمام. tomorrow متى يناسبك يا دكتور؟
ايمتى بتكون انتوا؟ بس انا عندنا الجورنال كلاب at 7 PM عندنا جورنال كلاب تبع البابس.
تبي نفس اليوم ولا تبي 5 العصر قبل 7 نخلص على
5 or what other option you said؟
ولا نفس اليوم؟
نفس اليوم يعني اليوم؟
نفس اليوم قصدي الساعة 1 الظهر يعني.
مثل اليوم مثل ما بتكون. which one is easier for me? Is both are fine tomorrow.
أتوقع 5 العصر مناسب حتى للشباب.
طيب 5 بكرة المساء. What are you going to talk about? AV access or just
AV access ونسوي ريفيو للأشياء اللي فيها تريكس.
طيب I was asking two question, guys. Two more question. I like if you have a question, be better.
Okay, yeah.
إن شاء الله عندكم شيء concern.
ونقولها.
All right. So see you tomorrow at 5.
إن شاء الله. على خير يا رب.
إن شاء الله. وأنت طيب. مع السلامة.